Good morning, ladies and gentlemen. We warmly welcome you to the specialty update on gastroenterology, the grand rounds in luminal disorders, organized by Ceylon College of Physicians in collaboration with Sri Lanka Society of Gastroenterology. Today's program brings together leading experts in gastroenterology to discuss common and challenging luminal gastrointestinal disorders in day-to-day practice. Without further delay, let's commence the program. To deliver the welcome address, I warmly invite Professor Namal Vijay Singha, the President of Ceylon College of Physicians for the year of 2026.
Good morning, ladies and gentlemen. Dr. Udita Kumarsena, the President of the College of Gastroenterology, and all my esteemed colleagues here from the Gastroenterology fraternity, Professor Madhurili Realla and colleagues. And this is another specialty updates we have organized in collaboration with the College of Gastroenterology this time. And the specialty update is a very important program we organize for many reasons. Out of all the programs we organize, this is the program we have highest number of participants, both on-site and online. And here we do a lot of organizing to do very formal, professional telecast and for the online participants. Secondly, I like this because one of our main objectives this year was to improve the unity and the collaboration between the sister colleges with CCP. So we have already had successful specialty updates with cardiology, respiratory, hematology, internal medicine, and today I have no doubt that we are going to have another very successful program. If you see the lineup, you can decide that, and I hope you all will get the maximum benefit out of this program. Thank you so much.
Thank you very much, sir, for those inspiring opening remarks. There will be 2 symposia with 3 lectures each. At the end of each symposium, there will be an expert panel discussion. We would like to invite your questions and comments at the end of the panel discussion. The first symposium will commence with the presentation on bloody diarrhea. I'm pleased to invite Dr. Wajira Samaravikrama, Consultant Gastroenterologist, National Hospital of Sri Lanka, to deliver the lecture.
Good morning, everyone. So at the onset, I would like to thank Ceylon College of Physicians, Sri Lanka Society of Gastroenterology, and the event organizers for giving me the opportunity to discuss this case scenario. So I will go through a case scenario of bloody diarrhea and focus mainly on management updates related to ulcerative colitis in 2026. So I will start with the case history. So this is a 33-year-old male patient, previously healthy, accountant, presented with bloody blood mucus diarrhea for 3 months duration. With he had 3 to 4 episodes of daytime symptoms with 1 or 2 nocturnal symptoms. And apart from that, he had urgency, tenesmus, abdominal cramps. He had no past recent history of exposure to any drugs such as NSAIDs or antibiotics, and there was no significant family history or contact exposure or recent travel history. So examination, he was averagely billed. Examination was fairly unremarkable. Specifically, there were no peripheral stigmata of inflammatory bowel disease. An abdominal examination was normal. Rectal examination was unremarkable except fresh blood. So what are the possible differential diagnoses, and how do we proceed with the further investigations. So this is a young male presenting with chronic diarrhea, which is diarrhea lasting more than 4 weeks, blood and mucus type, and symptoms suggestive of inflammatory sort of diarrhea. So the main differential we like to think of are infectious causes and IBD, mainly ulcerative colitis and Crohn's colitis. Apart from that, there are other minor differential diagnoses, but if we get an elderly patient, we need to maybe have to think of malignancy and diverticular disease, diverticular-associated colitis, and also ischemic colitis if we get an elderly, but this is less likely in this sort of patient. So investigations, so we need to start with the basic investigations to assess the degree of inflammation using full blood count. He had normal hemoglobin, CRP was mildly raised, and his liver functions were normal, and albumin was normal specifically. And it is important to do stool infectious screening at the beginning with stool full report, looking for amoeba, ovi, and cyst, and stool culture to exclude any bacterial infections specifically, and send stool for Clostridium difficile toxin. The guideline recommends a two-step approach for Clostridioides difficile toxin by initial test using a stool for GDA antigen, which is the highest sensitivity test, followed by toxin assessment. But in Sri Lanka, we don't have that, so we straight away proceed to toxin assessment. And then we proceed to colonoscopy, which revealed mild to moderate continuous inflammation from rectum up to proximal transverse colon, with the endoscopic severity suggestive of mild to moderate disease, and the terminal ileum was spared. So histology was confirmed chronic features of chronic inflammation and activity on histology. So we came to a diagnosis of ulcerative colitis. So why it is important to know about ulcerative colitis? Because the incidence is rising globally, especially in the developing countries. We know the pathogenesis is complex, which involves genetic predisposition, environmental triggers, alteration in gut microbiome, intestinal permeability abnormalities, and coupled with an aberrant immune response. So this can lead to increased morbidity, especially hospitalization, can lead to surgery, and can associate with increased risk of bowel cancer. So how do we approach to management of a patient with ulcerative colitis? Initially, we need to establish the disease extent and severity, followed by risk stratification, which should be done at the diagnosis initially. And we need to select an appropriate induction therapy, and we need to set certain goals to achieve, to set certain targets for the treatment, and we use certain medication for maintenance therapy, and we need to stringent follow up them closely to detect early relapse, and whether they are to detect if they are in remission, and to also we need to monitor for drug side effects, and where appropriate we need to screen with colonoscopy for bowel cancer screening at appropriate intervals. So how do we define the disease severity? So disease severity is not merely the burden of inflammation, but we have to consider the cause of the disease, the history of hospitalization, need for steroids, and prior medication failure, and also how the disease affects the patient, the quality of life and social functioning. So the inflammatory burden can be assessed using clinical scores and biomarkers like CRP and fecal calprotectin. Ideally, we need to do fecal calprotectin titer, which we don't have in Sri Lanka, and like serum albumin, and we have established endoscopic criteria to assess endoscopic severity. So on the left side diagram, we have Montreal classification, where we classify the disease extent into 3 types, E1 to E3. E1 is the proctitis, E2 is left-sided colitis, inflammation distal to splenic flexure. E3 is extensive colitis, which is inflammation proximal to the splenic flexure, which includes pancolitis with or without reflux backwash ileitis. So on the right side, there are 2 main endoscopic scoring systems that we use. Ulcerative colitis endoscopic activity of endoscopic index of severity, and Mayo score. So how do we risk stratify these patients? It is important to identify higher risk patients at the beginning. So what are those poor prognostic factors which we can recognize a patient who can develop complications of the disease and increased risk of surgery? So those features are younger age, extensive disease involvement, severe endoscopic activity, presence of deep ulcers, low albumin, high CRP, and history of hospitalization due to colitis. So what are the goals of the treatment? So there are several goals. The ultimate goal would be to induce deep and long-lasting steroid-free remission, and to prevent disease complications including surgery and hospitalization, prevention of relapse and disease progression, and ultimately maintaining a good quality of life. So how do we achieve these goals? By selecting appropriate advanced therapy in high-risk group, meticulous monitoring, and use what is called treat-to-target approach. So what is the treat-to-target approach? We set certain goals in early, intermediate, and long-term goals, and we need to follow up patients to see if they meet these goals. So the initial goals would be to attain clinical response and then clinical remission, normalization of biomarkers, especially fecal calprotectin titers and CRP, it was high earlier, and endoscopic healing and normalization of quality of life. Histologic healing in ulcerative colitis is supported by recent guidelines. However, it is not an ultimate goal at the moment, but it would be possibly be a future ultimate endpoint. So how do we monitor response? We monitor the response by clinically and using biomarkers, using endoscopic assessment, health-related quality of life, and there's increasing evidence to use endoscopic ultrasound, and as mentioned earlier, using histologic activity. So what are the management options in ulcerative colitis? We have medical and surgical options. Medical options, we have conventional therapies like steroids, 5-amino salicylate and immunomodulators, and we have advanced therapies, which are biologics and small molecules. So how do we select an appropriate therapy from above mentioned treatment? So we have to consider multiple factors, including disease-related factors, disease extent and severity, patient-related factors like age, whether the patient is pregnant or not, comorbidities, and patient preference and concerns. And we need to consider medication-related factors, how effective the treatment, how speed the onset of action is, the safety profile, mode of delivery, and for us, most importantly, cost and the availability. So how do we manage mild to moderate ulcerative colitis? If it is proctitis, we can start with topical 5-SA therapy, and if patient responsive, we can maintain with the same. And for the left-sided or extensive colitis, we can start combination with oral and rectal 5-ASAs, and if they respond to treatment, we can maintain. If they don't respond, we can use topical corticosteroids and oral corticosteroids for induction therapy only, but steroids are not for long-term maintenance. If we induce maintenance with induce remission with steroids, we can maintain either with 5-amino salicylate, but we need to consider immunomodulator therapy like azathioprine or 6-MP. And if the steroids fail or the patient becomes steroid dependent, we have to move on to advanced therapy. Obviously, we have to monitor the patient, the compliance, we need to exclude infections, and we need to see if they are on optimal dosage. So management of moderate to severe disease or high-risk disease, to induce remission, we can use oral corticosteroids or advanced therapies. We have multiple options here. I will discuss them in the next few slides. And for the maintenance, for corticosteroid-induced remission, we maintain with azathioprine or 6-MP. And azathioprine, so infliximab-induced remission, we maintain with azathioprine plus infliximab. And for the biologics-induced or advanced therapy-induced remission, we continue the same. But azathioprine should not be used as a monotherapy for induction. Steroids are not for maintenance, and there's no role for methotrexate in UC. So when do we consider advanced therapy? In high-risk patients, we need to consider them early. If the conventional therapy fails, or steroid-dependent or steroid-refractory cases, and refractory pouchitis. So these are the main classes of available advanced therapies. The interleukin IL-23 inhibitors, S1P receptor modulators are the newest agents. We have IV, subcutaneous, and oral preparations. And there are biosimilars which are lower cost compared to original medications, which is an additional advantage. So, how about the efficacy and safety profile of advanced therapy? For ulcerative colitis, so the data comes mainly from something called meta-analysis, but we don't have limited head-to-head trials. So, we know for the bio-naive patients, for induction therapy of ulcerative colitis, infliximab, vedolizumab, JAK inhibitors, and IL-23 inhibitors, golimumab, tofacitinib, those medications are highly effective. Adalimumab is relatively less effective compared to this medication. For previously bio-exposed patients, previous history of TNF failure, tofacitinib, ustekinumab, those are JAK inhibitors, or ustekinumab and IL-23 inhibitors come as most efficacious, where adalimumab and vedolizumab and SN1P receptor modulators are relatively less efficacious. Considering the safety profile, the vedolizumab, ustekinumab, and IL-23 inhibitors have the highest safety profile, where the steroids, TNF, and JAK inhibitors have relatively higher risk in terms of infection, basically, and certain risk of malignancies. So back to our patient. So the patient was initially managed as mild to moderate ulcerative colitis, where he was responded to oral mesalazine, and he had clinical remission at 6 months. However, we planned for colonoscopy, but patient refused because he was feeling fine. But 4 months later, he came with worsening of symptoms with blood and mucus diarrhea, this time 7 to 10 times a day. He was tachycardic with high CRP and low albumin. So what is the diagnosis and how do we proceed? So this is acute severe ulcerative colitis defined by Truelove and Witts criteria, which is a medical emergency. And about 1/3 do not respond to steroid, and there's 20 to 30% risk of colectomy. So we need to diagnose it, we need to have at least 6 blood-stained stools with at least one feature of systemic toxicity. So management of acute severe ulcerative colitis. First we need to send basic investigations, including CRP, serum albumin level, and we need to send stool infectious screening, including Clostridium difficile infection. And we need to start working up for biologics. In case of steroid failure, the patient should be ready to start biologics by day 3. So that is one important thing. And patient should have unprepped sigmoidoscopy to confirm the disease severity, and also to take biopsies to exclude coexisting CMV infection. Then, without waiting for the investigations, upon diagnosis of acute severe ulcerative colitis, you should start IV steroids without any delay, along with DPT prophylaxis with low molecular weight heparin. So then you should follow up the patients on daily basis, whether patient develop any complications like toxic megacolon, perforation, or excessive uncontrolled hemorrhage. So on day 3, we need to assess the patient using Oxford criteria, which defines steroid failure. If the patient is having more than 8 bowel movements per day, or 3 to 8 bowel movements with high CRP, more than 45, it is defined as steroid failure, and we need to move for rescue therapy. We have 3 options mainly: infliximab, cyclosporine, or surgery. And now we have evidence coming up for JAK inhibitors, tofacitinib and upadacitinib as well. But guidelines, you can select them on case-by-case basis. So our patient, initially he did not respond to IV steroids. So he had steroid failure, but we started rescue therapy with infliximab, for which he was responded. Most importantly, have we missed an opportunity to prevent this happening? At that point, we didn't know whether the patient had mucosal healing, whether the patient was feeling better. but we didn't have any biomarkers like fecal calprotectin level to make sure that which is an uninvasive marker to predict mucosal healing. So feeling better is not enough in IBD. We need to adhere to treat to target principles. So what would be the future in ulcerative colitis? There's increasing evidence for non-invasive monitoring, as mentioned, biomarkers and intestinal ultrasound. Histologic remission might be the ultimate target. The precision medicine concept is coming up, and there will be future expansion of advanced therapies and combination therapy and microbiome-based therapies. So this is my final take-home message, and you can refer to these guidelines for further information. Thank you.
Our next presentation is on chronic abdominal pain and diarrhea. I'm pleased to welcome Dr. Hishali Jayasundara, consultant gastroenterologist at District General Hospital, Nuwara, to deliver the presentation.
Good morning, everybody. So today the topic for discussion is a case-based discussion on chronic abdominal pain with diarrhea. So I'll start off with a case scenario, and then I will use this as a framework in evaluation of chronic diarrhea. And then we'll focus on management of Crohn's disease, mainly on advanced therapy, and then about the concept of treat to target with the role of intestinal ultrasound in managing patients with Crohn's disease, and finally how we can use our clinical knowledge in implementing when practicing in local settings. So given this chronic diarrhea and Crohn's disease, they are very broad topics. I will highlight only the main points within the next 15 minutes. So firstly, our clinical scenario is starting off with a 20-year-old male who presents with long-standing central and lower abdominal pain with watery diarrhea with a frequency of about 5 to 6 times during the daytime with nocturnal diarrhea as well. But he denies any blood or mucus, and also he complains of significant weight loss. He's a teetotaler and he denies any high-risk behavior or neither any family history for inflammatory bowel disease or any other autoimmune conditions or colorectal malignancies. So these symptoms had been lasting for about 3 years, and he had been investigated with a colonoscopy in midway, but it was documented as normal. So he was found to be pale with a BMI of 16, and he had no extraintestinal manifestations of IBD, no other features of any other systemic illnesses, found to have some tenderness over the right iliac fossa, and normal digital erector examination and perineal examination. So keeping this in mind, we'll move forward in how to evaluate these patients. So, according to the definition of chronic diarrhea, so this is persistent alteration from the norm, and the stool consistency should lie between types 5 and 7 on the Bristol stool chart, and also should have increased frequency, and the symptoms should at least for about 4 weeks duration. So our patient had all these features, so obviously he had chronic diarrhea. So then we move on to the history taking. So any patient who comes with chronic diarrhea, we need to characterize the type of diarrhea and mainly exclude whether it's a true diarrhea or pseudo diarrhea, that is increased frequency with normal consistency. And also we need to look at the timing, so because we can narrow down our differential diagnosis depending on the pathophysiology. And in addition to that, we need to look at the red flags, that is if it is recent onset, particularly if it is among elderly patients, nocturnal diarrhea, unexplained weight loss, severe progression, worsening of symptoms, presence of blood in stools, unexplained iron deficiency anemia, and family history for colorectal cancer, IBD, pancreatic and celiac disease. So in addition to that, we need to take a good drug history, because drugs can give rise to these loose stools, altered bowel habits, and then also a family history for autoimmune conditions or inflammatory bowel disease or malignancies, and also previous GI surgeries. So then moving on to examination, these things need to be focused on. We need to calculate the BMI, hydration status, and look for any signs of systemic diseases, look for any lymphadenopathy, pallor-icterus, and peripheral edema, and EIMs of IBD like pyoderma gangrenosum, orofacial granulomatosis, erythema nodosum. And if you're suspecting celiac, look for any rashes like dermatitis herpetiformis, do an abdominal examination and digital rectal examination to assess the perianal tone, and also to look for perianal fistulas and abscesses. So following a good history and examination, we can decide on how to evaluate this patient with investigations. So this is as of the algorithm, which was according to the BSG guidelines published in 2018. So in the interest of time, I'll just rush through. So first we need to start off with basic blood investigations like full count and inflammatory markers and thyroid functions, and celiac serology is not that important in our setting, and also then go for stool markers like fecal calprotectin, stool full report and fit test, and then further investigations like endoscopies, imaging and so on. If these basic investigations are normal, then we need to look for secondary possibilities. So back to our patient. So what are the differential diagnoses that is coming up in our minds? And so in a local setting, we need to think about a possibility of Crohn's disease, particularly like small bowel Crohn's disease or intestinal tuberculosis, and least likely possibilities like small bowel lymphoma, celiac disease, NSAID enteropathies, and GI vasculitis. So keeping this in mind, how did we investigate this patient? So basic blood investigations. So this shows that the patient has anemia and features of malabsorption, the TB workup and other opportunistic infection workup, thyroid functions were normal. Then what were the other supportive investigations? Stool investigations were normal, but fecal calprotectin was positive. And he underwent both upper GI and lower GI endoscopies and ruled out celiac disease, which was confirmatory with biopsies, and intestinal tuberculosis, and the colonic biopsies and ileal biopsies did not show any evidence of any IBD. So, but clinically, he did show some chronic inflammatory process. He had some tenderness over the right iliac fossa. So this prompted us to investigate further with imaging. So basically, we went ahead with ultrasound, which did show some localized collection in the right iliac fossa. So what we do next? So in resource limited settings, this is how we investigate. So we went ahead with CT abdomen pelvis, which confirmed there was a localized collection, and there it was in keeping in with disease of small bowel. So, but in real world, how can we investigate this patient? So if you have facilities like MR enterography, intestinal ultrasound, these are very good modalities in coming to a conclusion. And also, we have the other possibility of doing capsule endoscopy, but mind you, we need to rule out strictures, possibly after doing patency capsule or imaging. And if we definitely need tissue diagnosis, we need to go for a enteroscopy. So next, what we did in our patient was CT enterography. So this again confirmed the presence of small bowel Crohn's disease. So back to our patient. So what is the likely diagnosis? So he had fistulizing small bowel Crohn's disease. So how did we manage our patient? So first we treated the infection with the appropriate antibiotics and monitored him clinically and with biochemical markers and imaging. And once we did not go ahead with any ultrasound guided drainage. With antibiotics per se, his abscess resolved. And once he was free of infection, in the meantime, because it was confirmatory of Crohn's disease, he needs to be started on aggressive treatment. So we did the pre-biologic screening and then started him with anti-TNF therapy, which is ideal for penetrating disease with infliximab induction. And then we continued maintenance with the immunomodulator azathioprine and continued to monitor him biochemically and clinically. So now let us move on to our main topic, Crohn's disease. So this is a chronic inflammatory process that involves the entire GI tract, which can involve from the mouth to the anus, and it is of unknown etiology, but it is postulated that is a combination of genetic, immunologic, and environmental factors. And about 30% of patients will have small bowel Crohn's disease, about 40 to 45% about ileocolonic Crohn's disease, and about 20% isolated colonic Crohn's disease. So how do they present to us? So our patient had all these symptoms, so I will not go through again. And diagnosis is a combination of clinical, endoscopic, radiologic, and histologic findings. So there are certain disease modifiers like NSAIDs and smoking, so we should ask patients to avoid these. So depending on the location and behavioral pattern, we can classify this disease. So particularly in our patient, he had ileal L1 and penetrating B3 type of Crohn's disease. So now we move on to treatment concepts. So actually there is no cure. It should be individualized and there is no standard regime. So basically this is dependent on disease location, severity, and the presence of other associated complications like extraintestinal manifestations. So this is where the treat to target concept comes into play based on the STRIDE initiative. So the main goals are to control underlying inflammation. This is not only achieving both clinical and endoscopic, and lately they define transmural healing, and also to minimize disease activity at early stages, limit progression, improve long-term outcomes, to restore quality of life, and to reduce disability. So now we move on to conventional therapy. Actually, for Crohn's disease, there is no much say here. So guidelines do not recommend 5 ASAs either in induction or maintenance of remission of Crohn's disease. Then what about steroids? Steroids have only place in induction of remission. This could be either in the form of systemic steroids, but this should not be used for more than 2 months, or budesonide, which is a topically acting agent, and this is indicated only for mild to moderate ileal or ileocecal Crohn's disease, and this should not exceed for more than 12 weeks. Then we move on to immunomodulators. So there are 2 types mainly. So the purine analogs, that is azathioprine and mercaptopurine. Again, they are not indicated to be used as monotherapy either for induction or maintenance of remission. The SONIC trial did show that this thiopurine monotherapy was found to be inferior to infliximab monotherapy or combination therapy. What about methotrexate? There is a controversial recommendation. So BSG guidelines in 2025 does recommend the use of methotrexate as monotherapy for both induction. It's not suggested, but in ECHO 2024, they do suggest for induction and maintenance. But combination therapy with anti-TNF is recommended in all guidelines so as to prevent development of antibodies and improve the efficacy of anti-TNF. Now we move on to advanced therapy, that is the biologics. So the overall goal is to achieve transmural healing and to reduce complications and to reduce bowel damage progression. So first of all, the first class of biologics are anti-TNFs. So we have 2 types mainly, infliximab and adalimumab. So there are biosimilars also available. So all these biologics are recommended for moderate to severe Crohn's disease, and this is a very safe drug in pregnancy and breastfeeding. So you have IV induction for infliximab, and then you can continue maintenance IV or subcutaneous, and both these biologics are available in Sri Lanka. So these are very good first-line agents for fistulizing Crohn's disease. So that is why we used infliximab because of its availability and the ideal recommendation. We used infliximab in our patient as well, and also with patients with orofacial granulomatosis and Crohn's disease, and also with patients who have undergone ileocolonic resection to prevent recurrence. But again, it's a bit controversial because the PREVENT trial did not show any proven benefit. And adalimumab, in addition, is good for patients with Crohn's disease and spondyloarthropathy. So we do not have the facilities to monitor the drug levels, but Western countries do have these facilities to monitor the drug levels and antibody levels as well. So when using this, we need to think about reactions. These are the side effects, and there is a possibility of reactivation of infections like latent tuberculosis, hepatitis B, and also can precipitate drug-induced lupus, psoriatic skin lesions, and you should avoid live vaccines. And also, you should be cautious and should avoid in patients with prior history of demyelinating diseases, advanced heart failure, and other malignancies, and they have a tendency to there is a high tendency of giving rise to malignancies like lymphomas and non-melanoma skin cancer. Then, so a few words about certain trials. So CALM study showed that timely escalation with anti-TNF treatment results in better clinical and endoscopic outcomes in patients with Crohn's disease. And PROFILE study again recommends top-down treatment with immunomodulator therapy in patients who are newly diagnosed with Crohn's disease. So next we move on to ustekinumab. So this is an anti-p40 antibody which targets interleukin 12 and 23. You call it Stellara. So it is present in IV induction, and then you continue as subcut maintenance. This is again very safe for pregnancy and breastfeeding, and even in elderly patients. So this is effective for stricturing ileal Crohn's disease and in patients with both psoriasis and spondyloarthropathy, and along with Crohn's disease. Then the anti-P9 antibodies, which targets interleukin 23 only. So there are 3 types: risankizumab, mirikizumab, and guselkumab. So these were actually recommended very lately. So risankizumab, so sequence study shows that it was found to be superior over Stelara with previous exposure to anti-TNF. And mirikizumab, initially it was mainly recommended only for UC, but last year it was recommended for Crohn's disease. So the VIVID 1 and 2 trials showed that they were efficacious in both achieving induction and maintenance of remission. And guselkumab, this is the only biologic that comes with subcut for induction and as well as for maintenance therapy. So Galaxy 1 again showed that they were able to achieve remission after 12 weeks, and Fusion's trial is still going on, and this is to look at the efficacy for active perianal Crohn's disease. So, talking about vedolizumab, so this is a very gut-selective biologic. It is an integrin inhibitor. So, this is again very safe for pregnancy and breastfeeding mothers. This comes as IV induction, and then you can maintain this either as IV or subcut for maintenance. So, this is indicated again for moderate to severe Crohn's disease, and also particularly to prevent post-operative recurrence following ileocolonic resection, according to the REPREVIO trial. And finally, so this is the oral molecule, that is JAK inhibitor, upadacitinib, Rinvoq. So with this we keep it as a last resort when patients have failed previous other biologic therapy. So most of the time, patients do respond to upadacitinib, and you can salvage from surgery. But if patients are not improving, then ultimate source is surgery. So you need to be cautious when starting these. In young patients can worsen acne, and then also thromboembolic phenomena, major cardiovascular events, and also give rise to shingles. So that is why patients need to be vaccinated with Shingrix vaccine. So this is the timeline of introduction of biologics down the period. So when you talk about Crohn's disease, we need to talk about the role of intestinal ultrasound. So this is a point of care treatment, which is non-invasive and bedside thing, but we need expertise available. So this can be used for primary diagnosis and to monitor disease activity, that is particularly treatment response, and identify complications. And we can very well visualize the right colon and the terminal ileum. So what are the key features we look at on this intestinal ultrasound? That is the bowel wall thickness, where the cutoff is more than 3 millimeters, and bowel wall hyperemia using Doppler instead of using contrast. So the limitations wise, we cannot see the proximal small bowel whale and also the left colon and rectum as well. So a few words about pre-biologic screening before starting these biologics. We need to rule out tuberculosis because it is very prevalent in our country, and do the appropriate viral screening and give the appropriate do medications if they are found to be positive, and also see whether they have undergone timely vaccination. And we should avoid live vaccines, particularly if you have started a patient on biologic, should not give live vaccines at least 3 months after stopping the biologic. And also for if the patient is particularly on biologics like anti-TNF and immunomodulators, do regular skin checks for non-melanoma skin cancers and also cervical cancer screening. So finally, before I wind up, so these are the take-home messages. Persistent recurrent diarrhea with red flags should prompt further evaluation. Crohn's disease can affect any part of the GI tract and presents heterogeneously, so should have high index of suspicion. Timely recognition and early treatment with biologics can prevent complications such as strictures, fistulae, and surgery. Treatment target is to achieve transmural healing and requires regular surveillance for colorectal cancer, and ultimately requires multidisciplinary approach for optimal outcomes. So thank you for your presence and kind attention.
The third presentation is on loss of weight and diarrhea. I would like to invite Dr. Eranda Lakshman, consultant gastroenterologist, District General Hospital, Matale, to deliver his presentation.
Good afternoon, everybody. Thank you very much for giving me this opportunity. And today I'm going to walk into a diagnostic light box of a high-stake of diagnostic dilemma in modern gastroenterology, which is basically mainly intestinal tuberculosis and Crohn's disease. Why I'm going to interesting in talking about this topic is in terms of academic as well as the clinical medicine. If you made a wrong call in an endemic tuberculosis endemic country like Sri Lanka, can ended up in a catastrophic events like life or death situations. So to make into what I mean in reality, I would like to draw back your attention to my call 2 weeks back from the emergency department. This is one of my patients who presented to the Mathale emergency department, and you can see there is air under the diaphragm, which is suggestive of bowel perforations. So this patient was not like this before. 2 weeks back, he was in a gastroenterology clinic and who had a clear diagnosis of Crohn's disease and started with a high dose of prednisolone and worked away from the clinic. And it was very stressed to see me that he was presenting in the emergency department with a septic shock with evidence of bowel perforation. So I got the questions in my head, why after a protocol-based diagnosis and the treatment plan, why this patient ended up in catastrophic event with the ICU. To rule out this puzzle, I would like to draw your attention back to the initial presentation. He's a 42-year-old school teacher who complained of the 4 months history of loose stool, right side lower abdominal pain, with the diarrhea, which is 4 to 5 episodes, some on and off occasional nocturnal diarrhea as well, with some feverish feeling. And on examination, there was a right iliac fossa fullness, and she was pale, and he was cachectic with a BMI of 17. At the same time, he was concerned about the 6 kilograms of weight loss. And he was pale and with a hemoglobin level of 8.9 with a hypochromic microcytic picture with a high ESR and normal chest X-ray. So then we, after a series of investigation, we move on to the colonoscopy while he's awaiting for the CT. This was the real picture taken from my patient, and you can see as the endoscopist and the gastroenterologist, there is a large ulcer. This is in this area of the cecum where the ileocecal valve and the ileocecal valve and cecum. This is the large ulcer, and which for me initially it looks like I had a few differential diagnoses in my mind, whether this is a query Crohn's disease ulcer, whether this is the TB ulcer, or whether this is the adenocarcinoma of the cecum. So you can look at your, in this picture, the ulcer base is covering with the superficial ulceration with the stuff, with granulations, nodular granular lesions, // widely open ileal valve. So when I look as an endoscopist, I thought widely open ileocecal valve, which is called plateaulus valve, and also involved in the ileocecal valve, is this highly suspicious of Crohn's ileocecal tuberculosis. And my suspicion was very raised with the slough of the ulceration and the granular nodular lesions. And unfortunately, the registrar who was doing this colonoscopy has taken biopsies from the ulcer edge, which was only 2 to 3 biopsies. And we sent the samples to histology as well as TB-PCR. Later, we found that, and then we were awaiting for the histology, and the histology case as non-caseating granuloma. So, person presenting with the systemic illness, right iliac fossa mass, ileal thickening, and non-caseating granuloma. So, we thought we are dealing with a case of Crohn's disease, and we have started steroid, but this has led to catastrophic event of bowel perforation. Why did this happen? Because this is not Crohn's disease. And the debate is how did we miss ileochronic tuberculosis? And I would like to go back to investigations and critically comment on the investigations and refresh our knowledge. Tuberculosis is a great mimicker of Crohn's disease. And if we do the correct diagnosis, if we miss the diagnosis and immunosuppression error in a TB patients, there are a lot of catastrophic infective complications. And if we delay the Crohn's disease diagnosis and the treatment, he will end up in the strictures and perforations and the fistulas as well. So I thought first to think about more tuberculosis and their investigations. When we deep diving into that, we can easily diagnose TB or exclude TB and ended up in Crohn's disease diagnosis. So we need a lot of investigation, including blood, radiology, microbiology, histopathology, molecular and immunological as well. Why this my patient had a normal chest X-ray, which misled us to not to suspect more TB and more suspect Crohn's. But in extrapulmonary tuberculosis, large proportion of the people will not get pulmonary disease. So negative chest X-ray never rule out tuberculosis. So we made one mistake with the first chest X-ray. First mistake with normal chest X-ray, thinking more about Crohn's disease rather tuberculosis. And what about the MAN2 test? MAN2 test, so being in an endemic country and BCG vaccination, and in light of malnourished patient with systemic illness, negative MAN2 will never exclude tuberculosis. So we made another mistake here. Being MAN2 negative, we thought this is less likely to be TB, more in favor of Crohn's disease. MAN2, there are gray areas, which is 5 to 10 millimeter intermediate positivity, and in which case we have to run more tests to rule out tuberculosis. If significantly positive, there's no doubt we are going to treat. When it comes to the colonoscopy and the ileal region examination, actually we have to look into the specific signs which I already mentioned. Granular transverse ulcers are more commonly involved with the ileocecal tuberculosis. The longitudinal ulcers are the ones which commonly seen in the Crohn's disease. And usually platulous ileocecal valve seen in tuberculosis because of the destruction of the muscularis layer by the tuberculous bacilli, and the valve is kept open. Otherwise, in all people with normal ileocecal valve, it's kept closed. But in the Crohn's disease, with the strictures and the polyps, the lumen can be narrowed, but we can't see patulous ileocecal valve. And if we go more into the details, these are the one I was talking about. In other parts of the colon, we can see the cobblestone appearance and skip pattern of inflammation, which more in favor of Crohn's disease. But in my patient, I only had ileocecal one ulcer. So why this ileocecal valve is being chosen by the tuberculous bacilli for the most interesting part of the colon or small bowel. The thing is there are more abundant prey's patches lymphoid tissues, which is given them the more harboring environment, as well as reduce bile concentration, facilitate the bacilli survival, and also is to stagnate, motility is less. It's again more favor the survival of tuberculous bacilli. Therefore, ileocecal region is the most common part involved by the tuberculous bacilli. But in Crohn's disease also, ileocolonic disease is the one of the most common presentation in Crohn's disease. So then since the CT is not very easily producible in our setup. We did the CT. CT shows there were only mural thickening and lymph nodes enlargement. But we could not discuss more with the radiologist. If we discuss more, what are the things which favor tuberculosis, what are the things favor Crohn's disease? In the tuberculosis, the striking and most sensitive specific findings would be the very large lymph nodes, more than centimeter, with the necrotic center. It is very sensitive and specific. But in Crohn's disease also, there can be lymph nodes. Even malignancy adenocarcinoma can be lymph nodes, but not the necrotic center. And when it comes to the bowel wall thickening, ileocecal, in tuberculosis, the wall thickening is commonly asymmetrical, but in Crohn's disease, it could be symmetrical wall thickening. And there will be comb signs, which is due to the inflammation of the vasa recta. And these are the sensitivity and specificity. And these are the things I was already talking about. And microbiology and histological confirmation. And if any of these was positive, and we should diagnose as tuberculosis. Why we miss these 4 tests as negative? One thing is tissue culture we could not do there, and it takes more time. It will delay the diagnosis process. And histological demonstration of acid-fast bacilli. Actually, this is very, very low sensitivity test. Since extrapulmonary TB is a paucibacillary. Paucibacillary means the bacteria number is very, very less in the intestinal pattern. Usually the tests are easily and producible when there are bacilli more than 100 in 1 milliliter. But in paucibacillary, it is very, very less. So the chances to miss the acid-fast bacilli in a tissue is very high. So negative acid-fast bacilli in a tissue is not going to work, and it is not going to be a good test even. Histological evidence of caseating granuloma. Why we did not see caseating granuloma, but we only saw the just the granuloma only. So to get the understanding of that, the TB usually prefer the submucosa, and the caseating granuloma lie in the submucosa. But we took from the ulcer edge, where the inflammatory cells are there, and usually it will represent non-caseating granuloma, leaving the diagnosis is wrong. So what we have to do in this case of biopsy, we have to take deep through and through biopsy, at least 6 to 8 from the ulcer base. Usually when we suspect the cancer, what we used to do is take the ulcer edge biopsy 2 to 4, which cause significantly wrong in diagnosis in tuberculosis. And gene expert. What has happened in gene expert, we did the gene expert, but the nursing officer has put the sample into the formalin, which already destruct the bacteria and leave the diagnosis of normal gene expert. Gene expert shows there is active TB then and there, so it is diagnostic. We could have started TB treatment then and there, but we missed because of the negative gene expert. What come to, this is the gene expert, and other test in tuberculosis is the IgRA. This is host immune, this measure the host, that means human body reactions rather than bacteria. So positive this test doesn't mean acute tuberculosis or past infection. So this is only for supportive, but not to 100% diagnostic of active TB at that time. So I have summarized the specificity sensitivity in terms of TB and Crohn's disease. And the treatment, I think I would like to summarize how we should in an endemic country, if there is the diagnostic dilemma of whether this is the tuberculosis or Crohn's disease. So the rule of thumb is we should not miss the tuberculosis. So what we can do is we can start empiric treatment of anti-TB treatment and do all the tests or colonoscopy and colonoscopy and see the ulcer, whether this has improved or not. Usually, if this is TB, the people are going to improve in terms of fever, cachexia, weight loss. It will improve, and after 2 months of endoscopy, the ulcer will be completely healed. So the diagnosis is tuberculosis, so no need to worry. If it is not there, not improving, I think we are dealing with the Crohn's disease, so we can safely go back to the Crohn's disease management. I think I have come to the end of my lecture, and thank you very much for your attention.
We will now move on to the first expert panel discussion. May I kindly invite the distinguished panelists to the stage and take their seats. Dr. Sujeeva Kumarasena, consultant gastroenterologist and president of Sri Lanka Society of Gastroenterology, Professor Madhunil Niriella, senior professor and consultant gastroenterologist, Colombo North Teaching Hospital, Dr. Sanjeeva Arya Singha, consultant gastroenterologist of National Hospital of Sri Lanka. As well, I would like to invite the speakers of the first symposium to the stage as well.
Right. First of all, congratulations to the 3 speakers for your wonderful talks. And we'll open the floor for any questions before we ask a few ourselves. Right. If I may start with our first speaker, Vajira. Yes, you mentioned in your case history, I'm just trying to comment on a certain thing, the differential diagnosis in your patient. You mentioned in this patient who had about 2 or 3 months of bloody diarrhea, infective colitis. The chances of having an infection going on for so long is rather remote. In my view, I would say possibly 3 come to mind. One would be intestinal TB. The other 2 we don't really see very often. The other one being amoebic colitis and schistosoma, which is not prevalent in Sri Lanka. So for me, if bloody diarrhea goes on for 1 month, it's IBD unless proven otherwise. So that's an important thing to remember.
But so there was a question saying how frequently it is recommended to do endoscopy in patient with ulcerative colitis who was in remission. Yes. So initially, we need to make sure that the patient responds clinically. So if the patient responds clinically, and if he attained the clinical remission, what we call clinical remission, so resolution of symptoms, resolution of bleeding, then if resources are available, we can do calprotectin titer, which is not, we don't have. So in this setup, what we do is, generally recommendation is, if we start after completion of induction therapy with 5-ASA or steroids, wait for about, if the patient respond to that, wait for about maybe 4 to 6 months, and then consider doing a colonoscopy in the first place to confirm mucosal healing. But it depends. If the induction of remission is done by biologics, so the response to treatment is assessed at the end of the induction regime. For example, infliximab, please give the injections at 0 to 6 weeks and then 8 weekly. So at least at the end of 2 months, so we assess the clinical response. If the patient responded and in clinical remission, so again then patient remained well, when we can consider endoscopy in 6 months, about 6 months time. But in other countries, so because we can't put the patient continuously to do colonoscopy surveillance, which if the calprotectin titers are available, if it is less than 250 micrograms per gram, then it correlates with the endoscopic mucosal healing. In our setup, so we confirm mucosal healing around 6 months, and then if the patient is having any features of loss of response, then we can consider doing a doing a sigmoidoscopy or colonoscopy because we don't have the calprotectin cases. We don't do colonoscopy to assess mucosal remission, but it is indicated for surveillance for malignancies. That will depend on the duration and the comorbidities. If the patient is having PSC, we need to do it annually. And patients maintaining on remission and without any history of dysplasia or high-risk family history of malignancies, then we can space out to about every 2 to 5 years based on the risk. So there's a risk stratification, and based on that, we do surveillance colonoscopy. And if without PSC, at least after 8 years of diagnosis, if it is left-sided to extensive colitis, we should begin colonoscopic surveillance.
Yeah, Wajir, again, question to you. So I agree with Sanjeev that this is your patient is mostly a diagnosis between ulcerative colitis and Crohn's colitis, provided that the patient is immunocompetent. So in an immunocompromised patient, infective colitis comes into the picture even after 1 month of chronic diarrhea. But your patient was apparently an immunocompetent patient, therefore it's mostly IBD. So how would you differentiate for the trainees Crohn's colitis from ulcerative colitis on the history and examination?
Yeah, from the history and examination, usually ulcerative colitis present with more bleeding. So they can have abdominal cramps, but they may not get pain. That is one. And they will have rectal involvement symptoms like urgency and tenesmus. Crohn's disease can have rectal involvement, but they can have rectal sparing as well. So rectal symptoms are usually almost always there in ulcerative colitis patients. And and other features, especially in Crohn's disease, there may be involvement of perianal features of perianal involvement, and other extraintestinal manifestations are more common with Crohn's disease, and they can have significant weight loss, significant abdominal pain. They may get obstructive symptoms sometimes, Crohn's disease patients. Probably those are the main.
Yeah, in ulcerative colitis, it's basically the prominent rectal symptoms, the urgency, urge incontinence, and tenesmus and frank bleeding, which is not there in Crohn's colitis. Crohn's colitis generally spares the rectum, so there is no rectal symptoms. And for Crohn's disease, look for a prominent abdominal pain because it's a transmural disease. The abdominal pain is very early and it's like not related to the defecation, whereas in Crohn's, in ulcerative colitis, it's a colic that is associated with defecation. In between, there is no pain. If there is significant pain, significant malabsorption, weight loss, if there is active or passive smoking exposure, things like that, and perianal disease. Ask for perianal disease and look for perianal disease as a marker of Crohn's colitis.
Can I ask a question? Here, I'll put it to the panel, expert panel. In the ulcerative colitis patient, Ajira mentioned about calprotectin in these patients and in the diagnostic workup. In a patient blood and mucus diarrhea already suggesting inflammation, would you do a calprotectin level in the diagnostic workup? And also, would you go with a colonoscopy in this patient or just a sigmoidoscopy? Because a lot of referrals come to us asking for colonoscopies in these patients. And for the diagnostic purposes, the initial endoscopy, would you just do a sigmoidoscopy only?
I think the same question is asked from the audience as well. They're asking like 2 weeks history of loose stools, whether are you going to do a sigmoidoscopy in a hospitalized patient. I think the problem with right now is like they send, we get referrals for lower GI endoscopies, but then there is not a stoolful report in the ticket. So basic is important. Like if you get a patient with lower GI symptoms, just before asking for the lower GI endoscopy, because all these are invasive procedures and they have certain the complication rates. So best thing would be to do the basic investigation first like stoolful report, stool culture and ABST, basic full blood count, CRP, ESR and everything. The stool calprotectin does help, but then we don't have the values yet widely available. So what we get the positive and negative result, which doesn't mean much.
So I think if you are spending a lot of money on that, best thing is to do a sigmoidoscopy.
I think in acute ulcerative colitis, acute severe ulcerative colitis, there is no need to do a full colonoscopy. It is dangerous to do it actually, because in UC, the untreated UC, the rectum and the left colon is invariably affected. So limited prep, flexible sigmoidoscopy is enough. If it's a mild to moderate ulcerative colitis, you may do a full colonoscopy if there is a diagnostic differential between Crohn's colitis and ulcerative colitis. We must ask our questions from the other two speakers also. So, Eran, I want to ask you. So, your macroscopic appearance of that disease involvement in the ileocecal region was very characteristic of ileocecal TB. So, if you see ulcer on the ileocecal valve, which is a very significant ulcer distorting the ileocecal valve, and the valve is open because TB is a destructive disease and it starts in the ileocecal valve. That is almost always ulcerative colitis. In Crohn's disease, what you see is a stricture which is a little bit inside, and the ileocecal valve is still intact because Crohn's is a stricturing disease. It's not a destructive disease. So, what is your recommendation? What single investigation would you have done to differentiate the two after the colonoscopy?
Gene expert would be the single most reliable, quick way of differentiating acute TB or Crohn's disease. Actually,
that was negative in your patient. Probably it was done by a registrar. The samples were inadequate, and the nurse actually put it into a formal saline.
Yeah, usually it should be put into the sterile normal saline and sent for the PCR, formally destroy the live bacteria. That what was the disaster scenario which has happened. But the endoscopy, when we see that, it was clearly the tuberculous ulcer and all the endoscopic appearances. But for the academic purposes and for the educate the audience,
any other investigation you would do if your samples were destroyed for TB PCR? I mean, if you see that appearance, do a CT.
Yes.
Yeah, just do a CT, cross-sectional CT. You will see the symmetrical thickening. You will see large lymph nodes and ascites. If you see ascites, it's not Crohn's. It's most likely to be TB. Which is unless the albumin is very low with extensive Crohn's small bowel involvement, there is usually no ascites. But with TB, you get early ascites and very large necrotic lymph nodes. That's very important. I think we should not leave Hishali alone. We had to ask one question from her. Intestinal ultrasound is coming up in a very big way. It's point of care. It's very easily applicable. So you actually highlighted the two important points that we look at when we're doing an intestinal ultrasound in the setting of IBD. Can you, for the trainees, again mention the two criteria?
So the first is using the bowel wall thickness. So the cutoff is more than 3 millimeters. And also the other thing is bowel wall hyperemia. So instead of using contrast as for CT enterogram or MRI enterogram, we can just use Doppler studies and look at the hyperemia. And in addition, also we can look for bowel wall stratification and lymphadenopathy and also other complications.
Yeah, I think the cutoffs are little bit different. For the small intestine, it's 3 millimeters. For the large intestine, it's 4 millimeters. And not only the bowel wall hyperemia, you can look at the mesenteric hyperemia as well. So you turn on the Doppler and look at the bowel as well as the mesentery. And you will see that it's just lighting up because the bowel is hyperemic in IBD. Yeah.
One more comment for Ishali. You spoke a lot about the management of Crohn's. We also need to remember that we sometimes need our surgical colleagues' input as well. And we should not be frightened to ask for their help, especially when they have a stricture in the small bowel. A simple stricturoplasty is always helpful. There are also studies which have shown limited resections, especially in the terminal ileum, where they have done resections which have shown better long-term outcomes rather than biologics alone. So it's important to get the surgeons involved at the correct time.
There's another question. In GP practice, many elderly have skin manifestation with alteration of bowel habits. Do we have to refer them? I think any elderly person with alteration of bowel habits need to be referred for a low GI endoscopy. One. The second thing is skin manifestation and alteration bowel habits. It can happen with inflammatory bowel disease. You get pyoderma gangrenosum as well as other skin manifestation, and then of course with the, I think pellagra, you get dermatitis, dementia, and diarrhea. And the other thing is, I think celiac disease, you can get a G rash with the gluten sensitivity. Is there anything else that diarrhea and
There are lots of skin manifestations in IBD, pyoderma gangrenosum. I think you already mentioned erythema rhodosum. There are, yeah.
Yeah, just one comment, Charlie's talk. I think we should not consider surgery as a failure for Crohn's disease. It is part of the treatment spectrum of that is available to us. And if your patient is having always very localized ileocecal disease, so very selected patients who do not show any other areal involvement, and if it's only a fibrostenotic stricture with little inflammation, I think a limited resection is preferred in that kind of patients, sparing them from lifelong biologics and immunosuppression. Another point that I want to highlight is, what about the, you said combination is better, biologics plus immunomodulator like infliximab and azathioprine in the SONIC trial for Crohn's. What is the place of azathioprine if you are using more sort of the newer biologics, the anti-interleukins and the anti-integrins? Is there a place of combining that biologic with azathioprine?
It's not recommended, sir.
Yeah, why is that?
Well,
Because we combine azathioprine with infliximab to reduce the immunogenicity of infliximab. Infliximab is actually chimeric, so adalimumab is fully humanized. Still, the anti-TNF antibody formation is higher in the anti-TNF group compared to the anti-interleukins and the anti-integrins. So we don't, there is no need of, its antigenicity is less, there is no antibody formation. Again, ustekinumab antibody formation is less. Therefore, we don't need to combine the biologic with the azathioprine. Only if we use infliximab that you have to combine the two to reduce the antibody formation and increase the durability of the biologic long term. Let's finish off with Vajira, I think. You said now we have three options for acute severe ulcerative colitis. We have infliximab, we have cyclosporine, and we also have tofacitinib. What is the dose of tofa that is recommended for acute severe ulcerative colitis?
Yeah, it is recommended to use 10 milligram 3 times daily for initial 3 days, followed by 10 milligram BD for first 8 weeks, followed by maintenance 5 milligram BD. That's the usual.
Yeah, so induction is for moderately severe ulcerative colitis. If the standard dose is 10 BD, but in acute severe, you have to use 10 TDS. That's an important point. You have to use higher doses. Thanks.
I think you have already mentioned this, but there's a question. Indication to start biologics in initial treatment stage of Crohn's disease.
In Crohn's disease, because there is no much place for conventional therapy, we need to start on step-down therapy. So therefore, we need to start on biologics as early as possible so as to prevent complications. So this has been approved by all the recommended guidelines. So we need to start with biologics rather than, because unlike in ulcerative colitis, we have no place for conventional therapy.
I think it's very important to identify the patient at presentation who have high risk stigmata for complicated disease in the future, and then tailor their treatment. You have to treat them hard at first. So there is this top-down therapy where we use a lot of immunosuppressives early in the disease, not 1 year, not 6 months, within 1 month. Within 4 weeks, you have to decide that you are going to give these patients biologics and so on. And what are those criteria for ulcerative colitis from Vajira and Hishali? What are those criteria for Crohn's disease that will tell you that your patient on presentation is going to have a stormy long-term disease?
So if the patient has extensive involvement, and also if the patient is less than 30 years and perianal involvement or stricturing or penetrating disease, and previous resections, so these are the indications.
Yeah, in Crohn's disease, there are young patients less than 40 years, extensive bowel involvement, severe mucosal disease, presence of deep ulcers, very high inflammatory markers, high CRP, presence of low albumin, and history of hospitalization and probably steroid dependence and steroid refractory disease as well.
Where does the evidence come from? Which trial, suggested that top-down therapy, early top-down therapy is helpful for patients with IBD?
Is it a profile study?
Yeah, profile study. I think for the trainees, they should know something about profile study. That's a very important landmark study. The study actually looked for early biomarkers for aggressive disease, but what they found was that the patients who were treated early with aggressive treatment actually did quite well compared to those who were actually started on step-up therapy. Thanks.
Thank you so much. I mean, it's very interesting 3 lectures. And we are, our time is coming to an end. Thank you so much.
Thank you for the informative discussion. The second symposium will commence with the presentation on functional diarrhea. I'm pleased to invite Dr. Sunantha Nirupan, Consultant Gastroenterologist, National Hospital of Goa, to deliver this presentation.
Sit.
So, very good afternoon to you all. First of all, I would like to thank the Ceylon College of Physicians and the organizing committee of SLSG for giving me this wonderful opportunity. So, I think you all have saturated with listening organic GI disorders. So, let us discuss a case with functional diarrhea. So my overview of the presentation would be how to approach a case with functional diarrhea and what could be the basic introduction of irritable bowel syndrome and basic pathophysiology of irritable bowel syndrome and what are the evidence-based management of IBSD and what could be the current practical approach in our clinical setup. So let us begin with the case history. She is a 33-year-old lady presented with recurrent abdominal pain and low stools. Symptoms have been present since she was in university and it has been worsened within the last 6 months. She also reports bloating and the pain is related to defecation. It happens 2 to 3 times in a week. She opens her bowel 4 to 5 times per day without blood or mucus. There's no history of loss of appetite or weight loss and no family history of inflammatory bowel disease or bowel cancers and the rest of the history is unremarkable. Physical examination including DRE is normal. So how to approach a case with chronic diarrhea? So we discussed recently. So first we need to confirm the chronic diarrhea. Then second thing is to exclude the diarrheal mimics. And third important next step is to differentiate whether this patient is having an organic diarrhea or a functional diarrhea. So you are familiar with these organic causes of diarrhea. So the list is colorectal carcinomas, inflammatory bowel disease, microscopic colitis, bile acid diarrhea. So the list keeps scrolling. So how could we differentiate is by way of these organic red flag symptoms, or what we call alarming symptoms. So with the patient's symptoms onset after the age of 50 years, or unintentional weight loss, or rectal bleeding, nocturnal fever. Patient can wake up in the middle of the night with the pain, but wake up in the middle of the night with the diarrhea is not normal. Fever, palpable mass, or lymphadenopathy, persistent vomiting, family history of colorectal carcinomas, inflammatory bowel disease, unexplained iron deficiency anemia, or celiac disease. So if any of these features are present, then this will take us to a different path. So this patient doesn't have any of these alarming features. Young patient, chronic pain that has been there for a long time without alarming features, or more towards a diagnosis of functional diarrhea. So what is our next step? So once we confirm there's a case with functional diarrhea, then we need to apply a positive symptom-based criteria. So that is our Rome 4 criteria. So it has been updated in the 2016 and currently in the 4th iteration. So what does this criteria say? So you should have a recurrent abdominal pain at least 1 day per week. And it should be related to defecation. Please remember, it does not necessarily to improve with the defecation. It can be worsened as well. And the pain should be associated with changes in the frequency of the stool or changes in the form of the stool. So any two of these three features are there along with an abdominal pain. And also we should express some chronicity in these symptoms. What is chronicity? So these symptoms should be there for at least 6 months of period, and these symptoms should be active for at least last 3 months. So if any of these features are there, then that is irritable bowel syndrome. So irritable bowel syndrome is nowadays not a exclusion of diagnosis. It is a positive diagnosis with the careful history, careful examination. Once we exclude the alarming features, then that is irritable bowel syndrome. So once we confirm this irritable bowel syndrome, then we have this. We need to categorize this patient under subtypes. So there are 3 main subtypes. You may be familiar with these Bristol stool forms. The 1 and 2 are more slow transit forms, more constipated site, and 6 and 7 are more diarrheal site, more rapid transit. So during the bad days, if the patient has more than 25% of 6 and 7 and less than 25% of 1 and 2, then that's the irritable bowel syndrome, diarrhea predominant. During the bad days, the patient has more than 25% of 1 and 2 and less than 25% of 6 and 7, then that is irritable bowel syndrome, constipation predominant. So we do have this mixed picture as well. So why this is important again is the management obviously differs. So all the society guidelines recommend positive strategy rather than the diagnosis of exclusion. Why? Because most of the time it will be negative and unnecessary investigation, undue stress to the patient, and it's a significant healthcare impact. So we only need some certain diagnostic limited screening tests. What are these? Fecal calprotectin. So that is to exclude if the patient is having inflammatory bowel disease or functional causes, CRPs, and if the disease is endemic to giardia, then giardial stool antigen, and celiac serologies, and bile acid diarrhea. If you're suspecting bile acid diarrhea, then you could test for CCAT scan, or you could empirically treat. So only limited testing. So in our setup, we need full blood count, CRPs, and fecal calprotectin if available, because we have more than, we can't quantify the fecal calprotectin, either positive or negative. That will give some support. So only these 3 settings in the background history with the careful history examination and exclusion of the alarming features, then we could make a diagnosis of irritable bowel syndrome confidently in our patients. So the guidelines does not recommend a routine stool test, does not recommend a routine colonoscopy in a patient with less than 45 years unless there's no alarming symptoms, and no recommendation of allergic testing or hydrogen blood testing. So what is irritable bowel syndrome? So it is a very common GI disorder, affects millions of people worldwide, and it's not limited by geography. You may appreciate that more than 50% of referral to the gastroenterology and the primary care settings. So the global prevalence is 10 to 15%, and it is more common in women than men, and it significantly impacts the quality of life and work productivity. And it is a costly disorder because of repeated consultations, repeated investigations, so it impacts the economy. So I just would like to touch the basic pathophysiology of irritable bowel syndrome. So if the patient has had recent viral infection like viral or bacterial gastroenteritis or environmental factors or early life adversity like abuse or some genetic factors also play a minor role. So if these features are there, then the patient has a high chance to develop irritable bowel syndrome. So it is a gut-brain disorder. So where the way the gut communicate with the brain and the way the brain communicate with the gut in an abnormal manner, that leads to development of symptoms. Okay. Apart from that, there is also other proposed pathophysiological mechanism, visceral hypersensitivity, mild immune dysfunction and subtle inflammation, alterations of the microbial flora, increased intestinal motility, increased intestinal permeability. All these features are more prone to get the patient to develop irritable bowel syndrome. So once the patient got irritable bowel syndrome, then the triggers comes when we expose to certain kind of foods or certain stress-related events, then the symptoms comes. So next we move on to the management. So management is an integrated approach. It should be a combination of GI physicians, gastroenterologists, psychologists, and the GI dietitian. So we could divide the management into 3 parts: doctor-patient relationship, diet, and the drug, 3 Ds. So what is this doctor-patient relationship? It is the cornerstone of management of irritable bowel syndrome, because most of the time we will be talking with our patients with organic disorders more rather than a patient with the functional disorder. So we need to talk with the patient, give some reassurance. This is not a psychosomatic disorder like a patient, the symptoms are real. They have proposed pathophysiology, the symptoms are real. So we need to give some very good reassurance to the patients, and also give some reassurance that this is not going to turn into cancer, it's not going to turn into inflammatory bowel disease. That kind of approach should be dealt with the patient. Then the diet comes. So we can categorize the patient into mild, moderate, severe. So most of the patient comes under the mild category. So they do get better with simple reassurance, some dietary modification, and some symptomatic treatment. Some they need some second line treatment and other gut-directed psycho-behavioral therapies. So what is diet? So first line dietary advice should be given to all the patient. So the guidelines does not recommend the gluten-free diet or food elimination diet based on these allergies. So what they recommend is the healthy eating lifestyle. What we eat also matters, and how do we eat also matters. So that is important. If the patient is sensitive to milk products, then you can advise the patient to restrict the milk and dairy products. And also all patients should be advised to take a regular exercise. So then we could advise the patient to take soluble fibers. Soluble fibers are very good. The various randomized controlled trials has proven the efficacy of soluble fibers. It is very effective in global symptoms and abdominal pain as well. So you can see in this evidence, not the insoluble fibers, it's the soluble fibers we should advise the patient, the white bread, white pasta, white rice, something like that. Also, there's a pharmacological preparation in psyllium, which comes in the brand name of Fibogel. The next is a low FODMAP diet. You may have heard of this. So very extensively studied in irritable bowel syndrome. So FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyol. So it has been proved in various trials, which very effective in the management of global symptoms and abdominal pain. So I haven't added any of the FODMAP diets here. The reason is this is not going to advised by the physicians or gastroenterologists. This need to be modified or advised by the trained, skilled dietitians. So it's in a systematic manner. So this diet patient does not need to take this diet for lifelong. So this need to be some elimination, then kind of reintroduction. So it should be managed by a dedicated trained professionals for monitoring as well. What about probiotics in IBS? So there's no high quality evidence of probiotic in IBS. So ACG does not recommend because the heterogeneity in studies and the variability among the probiotic products. But again, there is a weak recommendation by the BSG. So if you think you really want to start the probiotics, you can start off that. You could try up to 12 weeks of time, then think whether to continue or stop the probiotic. Rivaroxaban in IBS-D, that is the main drug that has probably changed the management of IBS-D. So it is a gut-directed antibiotic, not systemically absorbed, generally well tolerated. So the dose is 550 milligram TDS 3 times daily for 14 days. So various trials, the target 1 and 2 trials has proven it is very effective in the management of global symptoms, IBS-D patients. And also it is also, keep in mind, you can treat this rifaximin with second time because it has been proven in the target 3 trials, which is a safety trial, which gives us the evidence that it has been treated twice in a patient who has failed the first treatment. Then comes the opioid receptor agonist. So we have aloxadeline and loperamide. We don't have aloxadeline here, but it is a very good drug to improve the global symptoms. But we have is the loperamide. So American guidelines, ACG does not advise the routine use of loperamide because it does not improve the global symptoms. But some of the guidelines, BSG and AGA, they suggest we could use because the important is to assess the patient, what is their predominant symptoms. Then you could think of starting the beneficial drugs. Antispasmodic in IBS-D, again, it does not improve the global symptoms. We know that the gastrocolic reflux are more common in irritable bowel syndrome patient rather than normal person. So they're more commonly presented with postprandial bloating, abdominal pain, that kind of symptoms. So you could start antispasmodic if the patients have that kind of symptoms. And 5-hydroxytryptamine 3 antagonist, which comes the alocetrone and ondansetron. We don't have alocetrone here, but ACG recommends alocetrone for women with severe refractory IBS-D patients. But we have is ondansetron, so it does not recommended in the American guidelines because again it is not given overall global symptoms improvement. But again, the patient is having severe diarrhea. We could start with ondansetron to improve the diarrheal symptoms. Peppermint oil, again, excellent studied, with very effective treatment for global symptoms and abdominal pain. The common side effects is gastroesophageal reflux. What about bile acid sequestrants? There is a prevalence of bile acid diarrhea in 10 to 13% of the patient in IBS-D. So you could test with the CCAT scan. It's not commonly available, so we could empirically treat with the bile acid sequestrants like cholestyramine. Again, American ACG does not recommend the bile acid sequestrant, again because of the global, it does not improve the global symptoms, only the diarrheal symptoms. But BSG recommends to use the bile acid sequestrant if we are strongly suspecting the bile acid diarrhea in a patient with nocturnal diarrhea or previous history of cholecystectomy, then if the previous first-line medical treatment fails, then we could think of this. So if the first-line treatments are failed, then we could think of adding second-line treatment, or we could add the second-line treatment at the earlier course of the disease as well. If the patient is having some behavioral issues, poor sleep, anxiety, or stress-related events. So what do we have is the gut-brain neuromodulators. So we have tricyclic antidepressants, SSRIs, also have SNRI and the tetracyclic antidepressants. So they are very effective in improvement of global symptoms and abdominal pain as well. So we could start with the low dose and titrate to maximum. So that's with the medical management. Then we have the behavioral therapy, irritable bowel syndrome. So if the symptoms are not improved with the 12 months of medications, then we could think of adding behavioral therapy. Again, we could start the behavioral therapy in the early course. As I mentioned earlier, the patient is having some behavioral issues. So what do we have? Gut-directed hypnotherapy, cognitive behavioral therapy, mindfulness-based stress reduction, and relaxation training. Again, we don't have the dedicated GI psychologists here, but we could refer to the general psychiatric team. So management of severe IBS, the patient is having refractory to these treatment, always review the diagnosis, because they need some further targeted investigation. Probably in that time we can think of doing a colonoscopy, taking the biopsies from the right and left colon to rule out microscopic colitis. That would give some additional support. And then if the IBS is confirmed, then integrated multidisciplinary approach is necessary. Iatrogenic harm due to opioid prescribing is not recommended, and you could try the combination of neuromodulators like adding SSRI to TCA is also beneficial, but be vigilant about the side effects. So back to a patient. This patient does not have any features of Alarming symptoms, investigations normal, so more towards the diagnosis of irritable bowel syndrome, diarrhea, advice with regular exercises, add on fiber gel, and daily restriction was advised, and she was referred to the nutritionist for low FODMAP diet and started on loperamide. Some improvement with this management, but again there are symptoms, so she was treated with rifaximin 550 milligram TDS of 14 days, and currently she is doing well. So that's the end of my presentation. So the take-home message is IBS is not a diagnosis of exclusion. It is a positive diagnosis with the positive strategy based on investigations, examination, and symptom-based criteria, and exclude the alarming symptoms. Only use limited testing. Colonoscopy is not required in all patients. And the therapy is individualized, no one size fits all. So based on the predominant bowel symptom, tailor the therapy. Dietary restriction should not be excessive, and always provide reassurance to these kind of patients. Thank you. Thank you so much for listening.
Our next presentation is on upper gastrointestinal bleeding. I'm pleased to invite Dr. Eranga Thalagala, consultant gastroenterologist, District General Hospital, Chile, to deliver his presentation.
Thank you very much. Good afternoon, everybody. First of all, I would like to thank CCP, SLSG, and Dr. Hiruni for giving me this opportunity. So today I'm going to speak about a patient presenting with acute upper GI bleeding. So first we will start with the case history. A 68-year-old man presents to the emergency department with 2 episodes of hematemesis and melena for 4 days duration. So what are the salient points in the history and examination that we should try to elicit? Because when we encounter a patient with upper GI bleeding, the possible underlying diagnosis should be established as early as possible, because pre-endoscopic management differs according to the underlying cause. And also, as endoscopists, we also would like to have an idea about it to anticipate and also to be ready with necessary endoscopic accessories during the endoscopic examination. So most of the time we can get an idea about the underlying cause from the history and the examination. So in this patient, he has a 6-month history of epigastric discomfort, early satiety, poor appetite, unintentional weight loss of 10 kilograms, and there were no history of NSAIDs or anticoagulant use, no history of chronic liver disease or alcohol use. On examination, he is pale, mildly dehydrated, tachycardic, blood pressure low normal, and otherwise it is normal, and the DRE revealed melena. So what are your thoughts about this patient? Could be due to variceal bleed or non-variceal bleed, or if it is a non-variceal, is it a simple peptic ulcer disease or something more sinister? Okay, so by definition, upper GI bleeding is bleeding originating proximal to the ligament of Treitz. It includes bleeding originating from the esophagus, stomach, and the duodenum. And it is a potentially life-threatening medical emergency. And even with current advanced therapy, it has a high mortality. For non-variceal bleeding, it's around 5 to 10%. For variceal bleeding, it is 20%. So usually they present with hematemesis if there is active bleeding source, active and rapid bleeding source. If there's a slower bleed, and if there's time for gastric acid denaturation, they might present with coffee ground vomiters. And melena is usually due to upper GI bleeding, but rarely could be due to small bowel bleeding, and also due to slow proximal lower GI bleeding. And if there's brisk and rapid upper GI bleeding, patient even present with hematochezia. And at times they can present with anemic symptoms, syncope, hypertension, tachycardia, postural dizziness, pallor, and confusion. So we should keep in mind that at times the apparent upper GI bleeding could not be actually due to true upper GI bleeding. There are some mimics of upper GI bleeding. So sometimes they might have non-GI bleeding, but we can mistake them for GI bleeding. Examples are hemoptysis, epistaxis, pulmonary hemorrhage, and oropharyngeal lesions. And also at times they might have pseudohematemesis and pseudomelena due to foods, drugs, and supplements. So how to classify causes of upper GI bleeding? So there are 2 main categories: variceal bleeding and non-variceal bleeding. So variceal bleeding could be due to esophageal varices and gastric varices and ectopic varices. This is an ectopic varix in the duodenum. So ectopic varix can be found anywhere along the GI tract. So non-variceal bleeding, there are various causes. There are peptic ulcer-related bleeding, could be related to the mucosal inflammation such as erosive duodenitis, erosive gastritis, erosive esophagitis, and all the bleeding could be due to malarial tear, and also there could be due to malignancy-related bleeding, and it could be due to vascular lesions such as angiectasis patches, duofoil lesions, or GAVE, or sometimes could be due to post-procedural such as ERCP. So this is an example of duodenal ulcer. This is a peptic ulcer. Here you can see the malarial tear, and this shows the erosive gastritis, and this is a malignant looking ulcer giving rise to bleeding, and this is the typical GAVE with the watermelon appearance, and this is an example of duofoil lesion. By definition, it's a aberrant artery coming perpendicular to the mucosa, and this is a angiectasis patch. So initial management is very crucial. Early intensive resuscitation reduces mortality in patients presenting with upper GI bleeding, and we should do rapid ABCD evaluation. And if there is a massive hematemesis, elective intubation is recommended to prevent aspiration. And if the patient is hemodynamically stable, we should treat them with IV crystalloid bolus of 500 milliliters over 15 minutes. And at least we should put 2 large wide bore cannulae and at least 18 gauge. And we should send blood for urgent full blood count, urea electrolytes and coagulation profile, and for grouping and cross match. And please keep patient fasting. Sometimes we get referrals. They say that the patient is coming with fasting, but when we ask about the fasting, patient is not fasting. So when it comes to blood transfusion, the restrictive transfusion strategy is favored over a liberal strategy. And the recommended threshold for blood transfusion when it is hemoglobin is less than 8 grams per deciliter. But if the patient is having cardiovascular disease or ongoing acute coronary syndrome, the threshold for blood transfusion is a bit higher. It is 8 grams. And we should avoid over-transfusion, and we should target for a hemoglobin level of 7 to 10. Then this is basis of this recommendation is to minimize portal hypertension, because if we over-transfuse and if the portal pressure increases, it increases the risk of rebleeding. And ROTEM or TEG-guided correction of coagulopathy is indicated for both variceal and non-variceal upper GI bleeding. And if the patient is having hemodynamic instability, we should inform the transfusion service and should activate the major transfusion protocol, and we should monitor them for vital observation using a score like NEWS. And also please inform the critical care and gastroenterology early. So some patients with upper GI bleeding need admission and intensive interventions, whereas others can be safely managed as outpatient basis. So how to identify the patients who need admissions and who can be managed as outpatients? So to do this, there are several score systems. So the commonly used one is Glasgow-Batchford score system. It is a pre-endoscopic score system, so it could be easily used to triage the patient. One problem with this one is, it is usually, we need the blood urea nitrogen level. So there are various other scores that we can use, and some emerging scores as well. And one word about complete Rockall score. So here, the complete Rockall score need endoscopic findings. So we can't use this to triage, but we can use this to assess the outcomes, rebleeding risk and the mortality risk. So there are some emerging modalities for risk assessment and to confirm upper GI bleeding in uncertain cases. So increasingly AI-based risk assessment scores are being developed, and also there are some new technological advancements, telemetric capsules. We can use these to confirm upper GI bleeding in uncertain cases, and also when the endoscopy is contraindicated, such as friable patients, COVID patients, and also when the patient is not fasting. But you can understand that these things are not available in our country yet. So then we have to, one most important thing is managing the coagulopathy. It is very important, and the coagulopathy and thrombocytopenia in cirrhosis do not directly predict rebleeding risk. In other words, if a cirrhotic patient is having low platelet and high INR, does not necessarily mean that that patient is having a high risk for bleeding. So ideally, we should do a rotum or a TEG and should correct the coagulopathy accordingly. And if there's active bleeding and if the platelet count is less than 50,000, then platelet transfusion is indicated, otherwise not. And most of our patients are on aspirin, no other antiplatelet. So if the patient coming with upper GI bleeding is on aspirin, then we have to look for the indication. If the aspirin is started for primary prevention, we can stop. And for non-variceal upper GI bleeding, if the aspirin is started for secondary prevention, we can continue. And nowadays, more and more of patients are on dual antiplatelet treatment. So if it is a non-variceal upper GI bleeding, it's a minor bleed. That means only a small volume, and if the patient is hemodynamically stable, we can continue both antiplatelet, especially if the patient is on drug-eluting cardiac stents. But if it is a major bleed, we can continue aspirin therapy, but we have to stop P2Y12 inhibitors such as clopidogrel, prasugrel, and ticagrelor. And if we stop P2Y12 inhibitors, we have to start within 5 days after hemostasis. So in variceal upper GI bleeding, we have to stop all antiplatelet, but we can continue aspirin if needed for secondary prevention. If the patient is on anticoagulants such as warfarin or new direct oral anticoagulants, we have to stop. And in here, hemodynamically unstable patient, we have to reverse the warfarin with prothrombin complex concentrate, vitamin K or FFP. And for direct acting oral anticoagulants, there are specific agents, but I don't think that we have these agents in our country yet. So if we have stopped anticoagulants, we have to weigh the bleeding versus thrombosis risk. And after hemostasis, if the patient is having a low thrombotic risk, we have to restart anticoagulants at or after 7 days. If the patient is having a high thrombotic condition, we have to resume within 3 days with heparin bridging. So this is what I have, the summary of what I have told up to now. So use of tranexamic acid in upper GI bleeding. For according to the current guidelines, tranexamic acid is not recommended in acute upper GI bleeding. This recommendation mainly based on HOLT trial, but there are some new evidence coming in favor of tranexamic acid in upper GI bleeding, but currently all the guidelines do not recommend tranexamic acid. So for the moment, there are no place for tranexamic acid in upper GI bleeding. So prokinetics improves the mucosal visualization and need for reduced repeat endoscopy. So we can use IV erythromycin, and recently the guidelines also recommend IV metoclopramide as well. So pre-endoscopic use of proton pump inhibitors. Proton pump inhibitors promote hemostasis by elevating intragastric pH and stabilizing the blood clot, and therefore it may reduce hemorrhagic stigmata but has no impact on mortality or rebleeding. most of the guidelines recommend pre-endoscopic PPI, especially if endoscopy is delayed or unavailable within 24 hours of presentation. So if we suspect a variceal bleed, we have to start vasoactive agents such as terlipressin, somatostatin, or octreotide. And also we should start IV third generation cephalosporin because it has a mortality benefit. And for terlipressin, up to now we were using bolus doses, but now there are evidence suggests that continuous infusion may be superior to bolus. So timing of endoscopy. For acute variceal bleeding, endoscopy ideally should be done within 12 hours according to the ESG and ASLD, but according to the BSD it is 24 hours. For non-variceal upper GI bleeding, endoscopy should be done within 24 hours. Emergent or urgent endoscopy should be done with persistent hypotensive patient with hypotensive shock despite resuscitation. So for endoscopic management, we have various modalities. We have injections, we have heat therapy, we have mechanical treatment, and we have topical treatment. So for variceal upper GI bleeding, for esophageal varices, we use banding and we use cyanoacrylate glue injection for gastric varices. And for non-variceal upper GI bleeding, combination therapy is superior to monotherapy. And the treatment modality depend on the underlying diagnosis. So these are some various endoscopic methods that we can use to treat. So this is direct contact therapy, heat therapy. So this is use of clips, and this is injection. This is hemostatic powder endoclot, and this is APC for GAVE, and this is banding for GAVE. So for peptic ulcer bleeding, we classify peptic ulcers according to the Forest classification. For 2C and 3, we don't treat endoscopically. Medical management is enough. For 1A, 1B, 2A, we have to treat endoscopically. The new guidelines suggest treatment for 2B as well, especially if there is endoscopic technical competence. So in peptic ulcer bleeding, if hemostasis is achieved, we have to use high dose PPI, IV bolus plus continuous infusion, or minimum to twice daily IV bolus for 72 hours. And the new guidelines suggest early start start clear liquids early. And also we have to test and treat for H. pylori at the index endoscopy and treat if positive. If the H. pylori is negative at the index endoscopy, we have to repeat testing within 4 weeks to confirm true negative. And we have to manage the anticoagulant and antiplatelet, as I mentioned earlier. And there's a new guideline. So most of these acute upper GI bleeding patient is having iron deficiency. So we have to start iron supplementation before discharge. So if the hemostasis is not achieved, we can do repeat endoscopy and try over-the-scope clips or topical hemostatic agents. Or if the endoscopy is unsuccessful, we have to refer for interventional radiology or surgery. So if a gastric ulcer is encountered, we have to take biopsies from the ulcer edges and the base, and we have to test and treat for H. pylori, and we have to confirm eradication of H. pylori, and we have to look for gastric atrophy and metaplasia. And if we suspect malignancy, we have to arrange surveillance endoscopy in 8 to 12 weeks time. And gastric cancer. So in our patient, most of the time the history suggests gastric cancer. So when to suspect gastric cancer? So in an elderly patient, if there's a new onset dyspepsia, even without alarm symptoms, that is an indication for early endoscopy. And if someone is having dyspepsia with alarm symptoms, irrespective of the age, we have to arrange early endoscopy, ideally within 2 weeks. And if someone is having dyspepsia with poor response to PPI, again, we have to arrange early endoscopy. So the few words about risk factors for gastric cancer. H. pylori infection is the most commonest risk factor, and also Epstein-Barr virus infection also can be associated with gastric cancers. the family history of gastric cancer, tobacco, smoking, reported salt taste preference, obesity, and GORD are the other known risk factors for gastric cancer. So, take-home messages would be upper GI bleeding is a medical emergency. ABCD and assessment and early resuscitation with restrictive transfusion improves outcome, and we have to do risk stratification, and we have to correct coagulopathy judiciously, and tranexamic acid is not recommended. Prokinetics improve visualization, and in suspected variceal bleed, start vasoactive agents and IV antibiotics immediately, and endoscopic therapy is highly effective. Gastric ulcer, we have to always biopsy and test and treat for H. pylori, and consider gastric cancer in elderly or those with alarm symptoms. And these are my references, and thank you.
The next presentation is on dysphagia. I would like to invite Dr. Supun Kulatunga, consultant gastroenterologist from District General Hospital, Kuliapitiya, to deliver his presentation.
Okay, good afternoon. Thank you, Hironi, for giving me this opportunity. Right, I think now it's 1:30. It's a very good time to do a dysphagia presentation, right? So everybody hungry, right? So you all know that you are going to have your meal in 30 minutes time, but a dysphagia patient, they don't know when they are going to have their satisfying meal, right? So with that feeling, let's go to dysphagia. So I'm not going to talk deep into treatments. I'm going to go to the algorithm of diagnosis, and what are the investigations we can do, and what are the latest advances in gastroenterology as endoscopies, what we can do, right? Okay, it's a simple case. I'm not going to resolve the case. I use this as a baseline to work out my lecture. So it's a male 58-year-old with a BMI of 32 on long-term treatment for hypertension, presented with difficulty in swallowing for 4 months duration. It's progressively worsening. He has this condition for nearly from his 20s, and mainly characterized by heartburn and regurgitation. I used over the medications. Then one fine day decided to go ahead with an endoscopy. Endoscopy showed this picture. So you can see there's a nice lining here. This white thing is the normal esophageal mucosa, and right. So what happened is no biopsies were taken from the upper GI endoscopy, and so the person who did the endoscopy said it's nothing serious, it's due to acid, and you have an incompetent valve. And the diagnosis given as Barrett's with hiatus hernia, and the patient was happy, and the doctor is happy, and given PPI, prokinetics, and advice given on lifestyle modifications. So he's reassured, so he went home and lived happily until 2 decades, and then he again presented with difficulty in swallowing, right? So again he decided to go ahead with an endoscopy, and it showed this, right? So that is nearly about 2 decades after his first OGD, right? So with that, let's go to swallowing. So swallowing is a complicated process, involves 3 phases: oral, pharyngeal, and esophageal. This oropharyngeal phase is very complicated. It involves how many muscles? Oropharyngeal swallowing. It involves 32 muscles with 6 cranial nerves, so it's very complicated. So my area is from the upper esophageal downwards, right? So what is dysphagia? Basically, it's difficulty in swallowing. We divided dysphagia into mainly 2 categories. It's oropharyngeal and esophageal dysphagia. Bit of epidemiology. It affects about 5 to 20% of the population, men and women equally affected. Prevalence increase with age, and going to statistics, it's the 10th ranked 10th as the commonest referral in USA. And you won't believe that the cost is more than managing GI cancer, because investigating dysphagia, it costly, endoscopy, investigations, everything. So the general cost is more than managing GI cancer, and it significantly affects quality of life. So going into simple things about oropharyngeal dysphagia. So oropharyngeal swallowing is a neuromuscular process, so it's mainly neuromuscular conditions affect neuromuscular dysphagia, stroke, Parkinson's, motor neuron disease, dementia. So I will leave. It's good to have an idea when a patient presents to you with difficulty in swallowing. You have to have some idea whether I'm dealing with esophageal dysphagia, whether it's oropharyngeal, because patient will say Gilinda Mari, right? So mostly this oropharyngeal dysphagia, they have these type of symptoms like coughing, choking, drooling of saliva, nasal regurgitation, dysarthria, dysphonia, and aspiration pneumonia. So if somebody have more of these symptoms, so that point more towards oropharyngeal dysphagia. So I will leave that to my neuro colleagues. So I'm going to proper esophageal dysphagia. So going into the causes, it mainly broadly can classified into three: motility disorders and mechanical structural lesions and specific conditions in the esophagus, right? So going into structural lesions, difficulty in swallowing can occur due to esophageal strictures, webs, rings, esophageal cancers, gastroesophageal reflux disease, and ulcers in the esophagus, and mediastinal tumors with external compression. Going into motility of esophagus, because it's a muscular tube with circular linear muscles, right? And there are conditions like achalasia cardia, hypercontractile esophagus, gastric outflow, esophageal gastro outflow obstruction, distal esophageal spasm, and infective esophageal motility. So a few questions, a few pictures actually. Can anybody see what this is like? So this is a esophageal stricture, right? Can you see the lumen has narrowed significantly? Can be due to malignancy, can be caustic injury. And this looks like a web. Sometimes it can be circumferential, or sometimes it may be crescenteric, right? I don't know whether you can see clearly. This is linear ulcerations from all four corners with luminal narrowing here. This is esophagitis. So we have a grading Los Angeles classification. It is Los Angeles grade D esophagitis. And this one, very nice thick circular ring near the gastroesophageal junction, and person has a hiatus hernia. So this is called Schatzki's ring. This happens due to thickening of the low end of the mucosa in esophagus. And what is this? So leptospirosis is very prevalent, and in the media we hear that to take doxycycline. So if you don't give correct advices to drink enough water, the pill can get stuck in the middle of the esophagus, and this is actually a doxycycline-induced esophageal ulcer, right? So you need to give correct advice when you prescribe medicine, right? So this one our friend had, esophageal carcinoma. Right. So going in, so this is again, so we got motility discussed and mechanical causes, and this is specific conditions. So we have esophageal candidiasis is another cause for dysphagia, and eosinophilic esophagitis, right? And so this Senker's diverticulum with a cricopharyngeal bar, they also can cause dysphagia. Symptoms may be oropharyngeal or typical esophageal. Right, so this is a nice diagram, nice picture. So it has circular furrows and linear and some exudates. What is this? This is eosinophilic esophagitis. And this is, I think you all know, like this is esophageal candidiasis. And this is a barium solo. You can see it's a cricopharyngeal bar with Senker's diverticulum. And I don't know whether you can see clearly. There's some fluid accumulated here, and it's tightly closed the sphincter, and esophagus is dilated. And it's the same again. You can see the macerated appearance, like soaked with water. It's like every time there's water. This is like the endoscopy appearance of a achalasia cardia, right? Right. So, so what are the alarming features when somebody has dysphagia? If dysphagia accompanied with weight loss, anemia, anorexia, and the symptoms are progressing, and if the patient is old, more than 50, and associated GI bleeding and persistent vomiting, then those are very alarming features, more suggestive of we are dealing with some sort of a malignancy. So dysphagia algorithm is fairly straightforward if you follow it correctly. Starts with history, so we can get some idea whether we are dealing with a motility or a mechanical problem. So if the dysphagia starts equally with both liquids and solids, it goes more towards a motility problem. And if the dysphagia starts with solids, then it becomes mechanical, and if it progresses, it can be peptic or malignancy. And if the dysphagia is intermittent, we don't see much of a seasonal variation here with a history of atopy in a young male. It can be eosinophilic esophagitis. And one thing I need to highlight to you is adaptive behaviors, right? Sometimes when we ask, can other, then they say no. And then when we ask, like, do you use water when you are eating? Then they say with every bite they are using. Unless you probe, they won't sometimes come up with that, right? So there are some adaptive behaviors these patients use. They use water, they take long time to eat, they chew a lot. So always ask about adaptive behaviors, right? And sorry, it's very small, right? I'll go through that. So diagnostic algorithm. So if somebody has dysphagia, the first line of investigation is upper GI endoscopy. Just doing upper GI endoscopy is not enough, because that's what happened in our patient's scenario. So they have done the endoscopy and just labeled as Barrett's without taking any biopsies. So biopsies is really important. Just normal endoscopy will not exclude eosinophilic esophagitis, so underlying dysplasia, especially in a Barrett patient. So biopsies is really important. Right, so if we from the endoscopy, if we can come to a diagnosis with a mechanical structural lesion, if we can see, so we are going this way. And if we cannot come to if we cannot find a cause for that, then so UEG, this is based on UEG. They asked to give a trial of PPI for 6 weeks. Maybe there are underlying GERD. So even with 6 weeks of PPI, if it does not settle, then we can go to the next line, manometry. Okay. Right. So again, in a list down manner, first line it's upper GI endoscopy with biopsy. Then we can do a trial of PPI for 6 weeks, and if it does not settle, then we can go to in our setting, maybe barium solo, and then we can see whether there's a motility problem, like slow passaging of liquid in the esophagus. And only in few centers we have high resolution manometry and topography. So I will discuss about this endoflip later, right? So this is how barium swallow shows. The left side one is it's a diffuse esophageal spasm. Can you see that multiple spasms in the esophagus? And the right side, it's dilated esophagus with bird's beak appearance. It's achalasia. So this is the image of a high resolution manometry. This red color indicates high pressure and blue is low pressure. So from upper esophageal sphincter to lower esophageal sphincter, more pressure in this area. So this is like a achalasia. So pH study, I won't go to detail. So this is just to show you. So we are getting a 24-hour recording. From that, with the calculation, we can come to a conclusion with how much time this patient is exposed to acid. Based on that, we can go for intervention if needed. What is this? This is a new device. This is called endoflip, endoluminal functional lumen imaging probe. So this is superior to high resolution manometry, but I think we don't have it here. This is just for as gastroenterologists, what are the things that we can do for dysphagia? For achalasia patients, the traditional treatment modality was Ehlers myotomy. But now we have a procedure called POEM, peroral endoscopic myotomy. So we have several gifted hands here who do POEM procedure, right? So we make a very small incision in the lower end of the esophagus, and we are going to the submucosal space. From there, we approach the muscles and we divide the circular and longitudinal and apply few clips. And so this is a very what you call non-scar, very simple procedure. I think we have very talented people here who do this procedure in about 20 minutes of time. So this is one thing we can do for achalasia. Another few words about Barrett's, since that was the base of our case. So if you see a segment of Barrett's, don't just mention Barrett's, take samples, because depending on the histology, we can categorize into these 5 types, right? So non-dysplastic Barrett's, and indefinite for dysplasia, low-grade dysplasia, high-grade dysplasia, and intramural carcinoma. Depending on this histological grade, the surveillance and the things that we can do is different, right? So I'm not going to detail about Barrett's. So depending on these 5 types, we can plan the interval of the next endoscopy and what are the interventions we can do for low-grade dysplasia and for high-grade dysplasia. So this is for the interest sake, as endoscopists, what are the things available and what we do. The one here, this is called radiofrequency ablation for a Barrett segment. So we ablate this dysplastic area. This is argon plasma coagulation. Again, we are ablating these dysplastic areas. Right, so and we have endotherapy for, so this is clearly a segment with intramural carcinoma. So we are doing what we call endoscopic submucosal dissection. We are making it, we are removing the whole mucosal part endoscopically. So gastroenterology is a very interesting field. I don't know how many registrars are here. So we have both medical and we have intervention both, right? So these are endoscopic surgeries we do. And another word about types of endoscopy that we can do. WE is white light endoscopy. So we can use actually some chemicals like acetic acid, lugols, iodine, methylene blue, and we can stain and we can clearly target the areas that we can biopsy. It will, rather than taking some biopsies haphazardly, we can add this chromoendoscopy and target and take biopsies. And the latter picture, so with the development of artificial intelligence, now we have endoscopy systems which the processor itself shows us where the lesions are, where these green squares, I didn't put them. It's what you call endoscopy itself has now these highlighted segments. So with AI, I think we will be able to diagnose more and more dysplastic segment in fusions. So this is a real case scenario of, again, carcinoma, how we have removed it and ultimately patient is cancer free now. So this is all I want to say regarding the dysphagia. So endoscopy is the first line, but it's no use unless you do proper biopsy. So normal endoscopy does not exclude some conditions. And high resolution manometry is the gold standard for motility disorders. And endoflip become increasingly valuable. And this endoscopic therapy has revolutionized some management of some conditions. Right, my references, and thank you very much.
Thank you, sir. We will now move on to the expert panel discussion. May I kindly invite the speakers of the second symposium and the following distinguished panelists to the stage. Professor Nilesh Fernandipule, Professor and Consultant Gastroenterologist, National Hospital of Sri Lanka. Dr. Mananjala Senanayaka, Consultant Gastroenterologist, National Hospital Sri Lanka, and Dr. Hasitha Vijayawantha, Consultant Gastroenterologist and President-elect of Sri Lanka Society of Gastroenterology.
Okay, so let me thank the speakers first for giving those overviews of those 3 topics, very practical and also very covering the theory of those topics also. Any questions that we want to start off until I get the questions?
Since we all are hungry now. So first, regarding the Supun's case, and it highlights the system failure basically. So because this patient has undergone an endoscopy. So the bottom line I want to highlight here is to medical registrars, if the patient is not responding to a trial of proton pump inhibitors and lifestyle modification for 8 weeks, the patient should be referred for upper GI endoscopy. And then just upper GI endoscopy would not do. Now you saw very well, the patient had undergone an endoscopy, then the biopsies had not been taken, and patient had been reassured wrongly. And he had continued to smoke, and subsequently you saw what has happened. So when you do endoscopy, remember that now you should be able, as medical registrars and future physicians, you should be able to assess the quality of the endoscopy. Now, as Supun very well explained, now endoscopy and endotherapy is very advanced, and it has evolved into a specialty on its own. And basically, endoscopically, we can early detect cancers and treat cancers and prevent development of cancers. And for Barrett's esophagus, there's a protocol for Barrett's surveillance. So all those things are there. So without taking much time, that's what I want to highlight regarding Supun's case.
There's a question from the audience which asks, I think goes to Ranga, active bleeding from fundal and gastric varices. If do any emergency radiological interventions are not available, can we do banding for gastric varices?
For gastric varices, banding would be technically very tricky one. So, to be honest, I never done banding for a gastric varices because after banding, it heals with the ulceration. So, making ulcer in a large fundal or gastric varices would be catastrophic. So, it is better to send the patient to a place where the facilities are available.
Also, I think there's a increased risk of perforation when you get a band and post-banding ulcer in the fundus. I think one I had to do as a salvage procedure in a place where we didn't have, and there was active bleeding and there was no option but to stop the bleeding. But I can remember I put the band on the fundal varices and it stopped the bleeding temporarily, but I knew it will ulcerate. So then actually I spoke to Madhunil and we transferred to Ragama, where he arranged glue injection before, within 2 weeks prior to the ulceration.
So I just finished the questions. How common is eosinophilic esophagitis in Sri Lanka?
Very difficult question.
I think there was a study done by Chamila, right? Once in Ragama.
A paper.
They did some studies, right?
So I think, yeah, it's only about in Ragama, right? I don't know, sir. We have a island-wide study.
No, we don't.
We don't biopsy much. That's the thing. So, because I think a lot of people doing endoscopy, physicians.
Do you routinely suggest to biopsy or suggest to biopsy in certain people, certain age groups? What do you do? Like patient with endoscopy, do endoscopy, everything is normal?
It's like this. If somebody says difficulty in swallowing, maybe slowness or something, if we can't find a specific reason from the endoscopy, so esophagus is very clear and we can't pinpoint any lesion, then better to at least take they say like to take 6 biopsies, but at least take 2 samples from the mid-esophagus, because most of the time what we see is endoscopy has been done and no cause identified, then refer to maybe manometry or barium solver, then it is also normal, and that's how it is. But at least dysphagia, we need to take mid-esophageal biopsies.
I think just to comment on that, I completely agree. If the endoscopy does not reveal any cause for the dysphagia, always take biopsies. The recommendation is lower esophageal biopsies, 2 or 3, and mid or upper esophagus, because to differentiate reflux changes. So the upper biopsy is the more important. So if you are take both. That will give a comparison for the pathologist to say the lower one may be reflux, but the upper one you can't explain by reflux. So yeah, just biopsy, and that will be very useful. And when would you biopsy histologically confirmed Barrett? Let's say the patient is diagnosed with Barrett's and comes back. And what is the biopsy protocol you will use?
For the surveillance, 4-quadrant, 2 centimeter apart, we need to take.
Yeah, basically, even with white light, the Seattle protocol is the standard one we take, but pay attention to any abnormal areas. I think paying attention to any mucosal and abnormality in a segment of Barrett's is as utmost important because you're going to miss dysplasia in that area. Thanks.
Yeah, can I also just add a comment? We are highlighting dysphagia. How do we? I feel many of the patients have globus as a main cause for dysphagia. I am not saying that we don't need upper GI, but I think we have to really go through clinically. Like all dysphagias are not equal, and when you
I think Supun highlighted oropharyngeal dysphagia. There is no need for an urgent endoscopy, but get your neurologist to see, or speech and language therapy, swallowing assessment. That is the line for oropharyngeal dysphagia. What we are talking about is esophageal dysphagia.
Just one more question to the audience. I don't know whether Supun will take it. Can you explain the terms distal esophageal spasms, diffuse esophageal spasms, nutcracker esophagus, and jackhammer esophagus?
I don't know who asked that question.
So I think I can't give the exact answer because it's all theoretical, but I think distal esophageal spasms and diffuse esophageal spasms are basically abnormal contractions. I think one is old term, one is a new term. I think the distal one is a new term, and the nutcracker esophagus and the jackhammer esophagus is basically abnormal contractions. You see, if you see, I think Supun showed a picture also.
Yeah, it's like this. So for high resolution manometry, these results are interpreted by Chicago classification, right? So that Chicago classification, they have various definitions. For endoflip also, there's an algorithm. For that algorithm, with that pattern, they put that. I think we can't diagnose that by symptoms or by appearance. It should be HRM based. So to diagnose jackhammer or diffuse spasm or whatever, we need to have that pressure pattern. So that pressure pattern is from that pressure pattern, Chicago classification is there. So I think it's not by clinically you can't diagnose what is what. It should be manometry based.
Yeah, okay, we should ask questions from all the speakers, to be fair. So this goes to Sunanda. So there is now Rome 5 criteria. What is the difference for IBS from Rome 4 to Rome 5? I think the trainees should know there is a new.
I think the actual criteria, I'm not aware of that, but probably the most stricter in a way to characterize it, definitely abdominal pain with more than one per week and associated features and the chronicity and those symptoms. So previously it was mentioned that abdominal discomfort, so now it's pain should be there in order to diagnose irritable bowel syndrome.
I think it's actually the other way around. Rome 4 was more strict. Rome 4 required pain, but now we also incorporate discomfort. Rome 4 needed at least once a week symptoms. Rome 5 now says lesser symptoms are also okay. Rome 4 had functional name, functional diarrhea, functional constipation. They have gone and removed that completely because that term is wrong, because now they use disorders of gut-brain interaction throughout the thing.
Yeah, it's something like paradigm shift.
Yeah, they in fact now highlight the multidisciplinary approach to managing the patients, because these patients are quite difficult patients and some of the most rewarding patients to get well, and some of the most difficult patients actually to get well, because they have all these psychosocial comorbidities. So those are some of the highlights, and they have given 2 criteria for the primary care and the gastroenterology clinical criteria and for research.
Yeah,
so
the nice guidelines.
Those are the difference, yeah.
Sunanda, now since we discussed during previous session as well as in this session, fecal calprotectin. So would you like to discuss the place of fecal calprotectin in a positive negative test? Like that's what we have. We can't do the fecal calprotectin levels when in comparison to much cheaper fecal local blood. Do you have any?
So it's fecal calprotectin is just assess the inflammatory conditions, right? So in our center, our country is only positive and negative that gives some values which probably if the negative fecal calprotectin we can exclude the inflammatory bowel disease, but the positive we can't exclude irritable bowel syndrome or inflammatory bowel disease. It's a diagnostic confusion. But the higher the rate could be some value, but again in our setup point of view we can't completely exclude with the qualitative value. The fecal occult blood is something assess the occult bleeding, so it's something different compared to calprotectin and fecal local blood.
So is it because fecal calprotectin implies neutrophilic inflammation of the gut and fecal local blood is bleeding from the gut? So now positive negative value, I don't think it has much of a value. Because except in only the exception could be that fecal local blood can negative in certain presentations of Crohn's disease, whereas where there is not much of bleeding. But in almost all other conditions, neutrophilic inflammation as well as bleeding is there. And when it comes to our setting, fecal local blood is much cheaper than fecal calprotectin, right? So if you have fecal calprotectin levels, it's a different story, and it is proportionate to the inflammation of the bowel. But then positive negative wouldn't make much of a difference.
Yeah, I'd like to make a comment. Now, it's probably time for us to ask from the labs the titer. We have positive negative, that is qualitative. We want quantitative, we need titers, because titers will only tell us we can compare. The most important thing is persistently positive fecal calprotectin. If you have an infection with the when the infection resolves, the calprotectin will become negative even in our setting. So it's still important. Whereas in IBD, you repeat it 1 month, still it will be positive. So that's an important thing even with the qualitative. But for disease monitoring in IBD, we need titers. That is number one. Number two, fecal local blood has no place in the management of the patients that we discussed today. I don't agree that it is for population screening. For individual patient management, if there is already blood and mucus diarrhea, what is the point in doing a fecal local blood? There is no. It is not recommended. It is not recommended in the workup. It is the fecal calprotectin that is recommended. Can I ask a question again? Yeah. We must ask something. Yeah, Sunanda, again, if for the trainees, if you have a patient who is refractory, IBSD, so diarrhea predominant, irritable bowel syndrome, what are the key differential diagnoses, maybe 3 that you want to highlight for the trainees?
Again, it depends on the how the symptom the diarrhea is. So again, we need to review the history again, whether the patient is having a nocturnal diarrhea.
No. It looks exactly fulfills the criteria for IBSD, but still refractory. What are the 3 differential diagnoses you want to highlight?
If female patient, it could be a microscopic colitis, and again, it could be a severe refractory IBS. And then probably we could think of bile acid diarrhea and small intestinal bacterial overgrowth.
Yeah, I think those are the 3 things for the trainees. It's either bile acid malabsorption, SIBO, or microscopic colitis. Remember, microscopic colitis classically in older patients, but now we tend to see younger patients also. So if they keep on coming back with symptoms, if they are refractory, probably a colonoscopy and right side and left side biopsies are indicated even in the younger group. Yeah. One question for Iranga as well. I think if you all can come up with a question.
Iranga, in the upper GI bleeds, basically, we see a lot of patients on tranexamic acid. You said something about that, and FFP also. what are the place of tranexamic acid? Is there any particular GI bleeds which you can try it out, or and also FFP? Is there place for FFP in patients?
So, according to the HOLTIT trial and the most recent guidelines, so there's no place for tranexamic acid in upper GI bleeding, but there are some recent evidences coming. There was one RCT done published in 2024. It has revealed tranexamic acid could reduce rebleeding risk in child B and C patients, but there's no change in mortality. And there's another meta-analysis again published in 2025, which included more than 2 million patients, and it included the HOLTIT trial as well. It again showed there's some benefit in the sense of rebleeding risk, but there's another study which also included more than 2 million patients. It shows clearly that it increases thrombotic risk. Therefore, at the moment, even the 2025 BSG guidelines do not recommend tranexamic, but there may be changes in the future.
I think for the trainees, let us say at present, tranexamic acid don't give, because it will just increase the risk of portal vein thrombosis, which we don't want our patients with bleeding to have, because then we have to anticoagulate. So only ROTEM-based correction is recommended. You have to go by a ROTEM or a TEC in your patients, and doing a timely endoscopy, variceal banding, and achieving hemostasis is probably the most important thing. If you achieve hemostasis, you don't need the other things.
Just to add to that thing, I mean, in your routine patients, you would definitely not give, but in patients who are malignancy-associated upper GI bleeds, I think there have been some studies where tranexamic acid has been useful, but that is something because endoscopically sometimes we don't have anything much to offer them. So that is something that one possible place where you can use it, I think. I think in interest of time, now that we have got time is up, we'll hand it over back to the organizers to wind up the session.
Thank you for that insightful discussion. I would like to call upon the President of Sri Lanka Society of Gastroenterology, Dr. Sujeeva Kumarasena, to hand over the certificates of appreciation to our esteemed speakers. Dr. Vajra Samara Vikrama, Dr. Hishali Jayasundara, Dr. Aranda Lakshmi, Dr. Sunanta Nirupan, Dr. Eranga Talagala, and Dr. Supun Kulatunga. Thank you, sir. I would like to call upon the President of Ceylon College of Physicians, Professor Damal Vijay Singha, to hand over the certificates of appreciation to our esteemed panelists today. Dr. Sujeeva Kumarasena. Senior Professor Madhuril Viriela. Dr. Sanjeeva Arya Sinha. Professor Nilesh Funandipule. Dr. Mananjula Senanayaka. Dr. Hasita Vijayavanta. Thank you, sir. Ladies and gentlemen, thank you all for your participation and contribution today. We would like to invite all the speakers and the panelists on stage for a photograph.